Okay, sir. So shall I begin?
Yeah.
Okay, sir. So greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from ClearNet, serving as the allocator session assistant to ensure a seamless experience. ClearNet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet served as the digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session, Anesthesia and Cardiomyopathy. Now, I would like to hand the session to Dr. Radhakrishnan, sir, to proceed with the session. Over to you, sir.
Thank you, Planet and Riba, for airing us. I hope you are keeping absolutely fine. My dear friends, fellows of ICA, President ICA, Executive ICA, members of ICA, good evening to you all and welcome to Wednesday evening webinar of the Indian College of Anesthesiologists. Incidentally, today is the 250th webinar of ICA. ICA had been doing this webinar very punctually on every Wednesday on a quality area by the excellent brains of India and outside. And these days, we are keeping the webinar content on the YouTube also. Today also, another webinar is going to be released. This particular webinar is on some uncommon cardiac diseases. It's mostly on the cardiomyopathies and anesthesia. It was uncommon once upon a time. Now, since the pickup rate is very high, it is almost becoming common. Now, this particular webinar is going to be handled and moderated by Dr. Mukul Kapoor, Professor and Head of the Department at Amrita Institute of Medical Sciences, Faridabad, Delhi. Mukul, an excellent anesthesiologist and a real friend, an editor, author, speaker, and a good gentleman for everybody. And he has concerned to be with his colleagues, not his colleagues, our colleagues. Today, we'll be talking on this particular topic. Before that, I would like to say that yesterday evening, we concluded the New Delhi Postgraduate Assembly second edition through University College of Medical Sciences, Delhi. This was the second edition, 5-day-long program. What are the very good programs which is conducted as a teaching program in anesthesia in recent years? Basically, our idea also is that this is a finishing lectures on certain subjects there. And we don't discuss hard theory. We discuss only the practical case discussion and certain areas which needs further emphasis, especially in the case discussion. And as it stands, so on the day of discussion, the matter will be revealed to you. And yesterday, till around 5:30, we are holding on to this particular postgraduate assembly, and we are able to do it very well. Now, even though we said earlier that we may be able to do another postgraduate assembly in India, probably at Bangalore, I'm sorry, owing to some technical reasons, we are not able to proceed with that. And we will be having our third edition of the postgraduate assembly only in 2026. And President IC is here, Dr. Gershis will be telling about the details of that very soon. And the next highlight of us is our annual national conference, which is going to be international conference, going to be at Jodhpur in the month of August. And with this, I welcome Dr. Mukul Kapoor and his team to the webinar. And before that, I request Dr. Jayashree Sood, well, our president of the college, to address you all. Over to you, madam.
Thank you so much, sir. Thanks a lot. And I think you've done a good introduction. Just to add a little more, that we have of course, as the yearbook of anesthesiology, of which Dr. Mukul is the editor, and the JICA, that is the Journal of Indian College of Anesthesiologists, which is also released online as well as a hard copy. Plus, we have various fellowship programs running in different hospitals, which you can see on our website. And of course, Dr. Mukul will be now starting the show. But I would just like to add that today I'm so happy that my student, who was a student, that Dr. Dheeraj, now such a big, renowned cardiac anesthesiologist, is going to be presenting in the webinar today. So I'm really very happy, Dheeraj. Thanks,
you,
Mukul. Please start. Mukul, please go ahead. Yeah.
Thank you very much, ma'am. Thank you for the introduction, sir. And thank you for handing over this opportunity to us. We are very happy to say that we have been regularly conducting all the webinars possible from our institute, and our institute has been very active in conducting webinars. And madam and sir, I would like to say that I was there at the PG assembly also, and it also went off very well. That is for information for all those who are attending the webinar. The PG assembly is an excellent thing we have started, and this PG assembly, we plan to make it as good as possible, and maybe after a few years, compare it with the New York PG assembly, and no less. It is growing very fast, and I'm sure it will grow and become something really worthwhile. And so now we start this webinar, and this webinar we thought we'll talk about some uncommon diseases and anesthesia. And so we thought that we can target cardiomyopathy, which not many people read about, or not many people are aware of. Not many people have experienced patients who have got cardiomyopathy. So we start the webinar with the first talk by Dr. Dheeraj Arora. Dr. Dheeraj Arora is a senior consultant and assistant professor in cardiac anesthesiology at Amrita Institute of Medical Sciences and Amrita School of Medicine. He is an academician, and he has 52 publications. He has written 8 chapters in books. And currently, in addition to his present role, professional role, he also holds the post of Dean Academics for the Indian College of Cardiac Anesthesia, which is an organ of the Indian Association of Cardiothoracic Anesthesiologists. And Dheeraj has been very active in academics for quite some time. He has been taking regular lectures. He's also the coordinator for the National Board for Cardiac Anesthesiology. Over to you, Dheeraj.
Thank you, sir. Am I audible, sir?
Yeah, you are.
Thank you, sir, for the kind introduction, and thank you, ma'am, and thank you, Dr. Radhakrishnan, sir. My topic is hypertrophic cardiomyopathy. What are the anesthetic considerations? Again, greetings from my institute, Amrita Hospital, Faridabad. This is the outline of my talk. It will be like a introduction that includes definition, pathophysiology, clinical manifestation of HCM. Now, I will focus on cardiac imaging also, because that is very important, particularly with regard to HOCM, and what are the various guidelines which recently came with regard to HOCM, and what are the treatment. And lastly, I will go for anesthetic considerations. Before starting introduction, I will start with a case which we had conducted in our hospital. She is a 29-year-old female, which presented with dyspnea on exertion grade 2 to grade 3, history of palpitation for the last 1 year. There was no history of loss of consciousness. Otherwise, there was a family history of sudden cardiac death. She was a hypothyroid on altroxin and metoprolol. And on examination, she was conscious. There was average build, respiratory bilateral chest was clear. Only there was ejection systolic murmur at aortic area, and airway was normal. Investigations were also within normal limits. ECG only showed left ventricular hypertrophy, and X-rays also revealed left ventricular hypertrophy. Transthoracic echo revealed hypertrophy of the left ventricle. LV was normal. There was septal hypertrophy of left ventricle causing LVOT obstruction with a gradient of 120 by 55 millimeter of mercury. That is a significant finding, along with mild mitral regurgitation. Now, this was the X-ray of that patient. You can see the left ventricular hypertrophy. Now, she was planned for septal myectomy. This is a procedure which is used to cut the septal hump, that is the LV, which is a septal hypertrophy, which is known as the Morose procedure. General anesthesia was induced using standard techniques. Cytometrate was used in this patient, maintained with oxygen, air, and isoflurane. Standard monitoring was used along with invasive monitoring, and TE was also used in this patient. This is the transesophageal echo probe, which is connected with the echo machine. Now you can see this is the transgastric mid-papillary view of the left ventricle. You can see this, there is a left ventricular hypertrophy. This is the left ventricle. These are the papillary muscles, anterolateral and posteromedial. So there is a left ventricular hypertrophy, which is clearly revealed. There is a 3-dimension of that. We do it regularly in our patients. Like you can see in this patient, now this is the interventricular septum. Now this is the problem. You can see there is a left ventricular hypertrophy, where there is a septal hump is there, and the mitral wall is aligning with this septum. So this causes the left ventricular outflow tract obstruction, which is determinant for this patient. Now you can see the dimension is around 2.3 centimeters, and the left ventricular hypertrophy was 2.9 centimeters. So bypass was established after giving heparin, and it was uneventful. The muscle was resected. This is the excised muscle of the left ventricle, which was, and you can see this is the post-operative image, post-bypass transesophageal echo. You can see the excised portion, and you can see there is a long gap between the AML of the mitral valve and the interventricular septum. And the gradient was also, again, it is non-significant after the surgery. Now, this is again the post-bypass transgastric view of the left ventricle. Post-operatively was uneventful. Only thing we used Holter, that is used as a standard protocol. She was discharged on the 6th post-operative day. There was mid-cavity gradient of 18 millimeter of mercury, which was 55 millimeter of mercury pre-operatively. Now, if it's coming to the introduction, what is cardiomyopathy? Cardiomyopathy was a term which was devised in 1957. It is a disease of the heart muscle that can be inherited or acquired and can affect the people of all ages. It affects the shape, function, and electrical system of the heart, and incidence is 1 to 500 in United Kingdom. There are various definitions which came from 1980 from WHO. Then in 1995, it was revised again with WHO and ISFP. Then a standard definition came in 2007 by European Society of Cardiology. It's a working group on myocardial and pericardial. But they have defined that myocardial disease, the cardiomyopathy is myocardial disease in which the heart muscle is structurally and functionally abnormal in absence of CAD, hypertension, valvular disease, congenital heart disease, and which is sufficient to cause myocardial abnormality. It may be DCMP, it may be hypertrophic, it may be restrictive, or it may be unclassified. Then recent guidelines came in 2020, which is the AHA-ACC guidelines for diagnosis and treatment of patients with hypertrophy. And my talk will be based on these guidelines. I will use the various guidelines they have published. Now, what they have defined that it is correct that hypertrophic cardiomyopathy is characterized by when there is a left ventricular hypertrophy in absence of any cardiac, systemic, and metabolic disease, which is capable of producing magnitude of hypertrophy evident in a given patient, and for which a disease-causing sarcomere is identified and genetic etiology remains unresolved. Again, it's the most common inherited cardiac disease with 1 to 500 incidence, autosomal dominant. And if you see from echocardiography point of view, any end diastolic dimension of more than 15 millimeter is significant. And in patients with family history of HCM, any dimension of more than 13 to 14 millimeter of mercury is significant to diagnose the hypertrophic cardiomyopathy. The hypertrophy may be asymmetric, it may be concentric, it may be mid-cavity, or maybe it can happen anything, like it may be asymmetric or concentric. But HOCM, obstructive myocardopathy, is important, which is commonly seen in 70% of patients. The patient may present with diastolic dysfunction. There may be hypertrophy or ventricular stiffness because the LV mass is increased. There may be shape distortion of the left ventricle, again leading to diastolic impairment. The LV functions may be normal, the systolic function may be normal, but in the end, in the later stages of the disease, there may be biventricular function which may dysfunction and which may be the cause of death in these patients. Now, why it is important? There was a paper published in Journal of Atrial Fibrillation in 2019. We have defined that there were 5 athletes which died because of HCM. There was a sudden cardiac death in female athletes and lesser learned heterogeneity in expert recommendation and pitfalls. They have defined. So that is important. Why this disease is important? Because we have lost about 5 to 6 and it has been published in Journal of Atrial Fibrillation. And it is the most common cause of sudden death in hypertrophic cardiomyopathy. If we see the pathophysiology depends on the degree of left ventricular outflow tract obstruction. From anesthetic point of view, we should always look on echocardiography report in these patients, and we should look what is the degree of left ventricular outflow. And the LVOT obstruction is the only thing which causes symptoms in these patients and which are detrimental. It may be less than 30, the pressure gradient, if it is non-obstructive. And if it is more than 30, only during provocation, it is labile. And when it is obstructive at rest, the pressure gradient will be more than 30 millimeter of mercury. So that is important thing. And the clinical manifestation, it may start in adolescence, sometimes in infancy also. There may be dyspnea, there may be chest pain, there will be non-specific symptoms will be there like dyspnea, chest pain, syncope. Syncope is the most important symptom, which should alert us that we should do something for this patient. Atrial fibrillation, there may be thromboembolic events, and there may be, if there is a dynamic LVOT obstruction, it causes systolic anterior motion of the mitral valve, and there is a mid-septal contact, and sudden cardiac death may happen in 1% of patients. Sudden cardiac death may happen whenever there is a sustained ventricular tachycardia, when there is a family history of sudden death in these patients, when there is a history of syncope. Whenever there is a history of syncope, it is a dangerous sign. We should always do something for these patients. And whenever there is a left ventricular hypertrophy of more than 30 millimeter, again, this is a dangerous sign for sudden cardiac death in these patients. And whenever there is an abnormal blood pressure response to exercise, again, it's a cause of the sudden death in these patients. Now, what is the role of cardiac imaging? I will focus few slides on cardiac imaging, which is very important from a general anesthesia point of view, as well as we are doing routinely in our OTs, that is from the cardiac anesthesia part, like echocardiography. It is the primary imaging modality in these patients. Then if we don't get the information, or like the information is not gathered from echocardiography, then we should do the cardiac magnetic resonance imaging, like cardiac MRI in these patients, which complements the information if the echocardiography is inconclusive, to establish the diagnosis, to assess the severity of the phenotype, or whenever there is a storage disease is there or other problem is there, then we should characterize the dynamic LVOT obstruction. What is the role of mitral valve? What is the systolic anterior motion of the mitral valve is there? What is the degree of mitral regurgitation in these patients? Whether the mitral valve is abnormal or not. Then we should document the maximum valve thickness, which is very important. The chamber dimensions is very important. The systolic function is very important, or whenever there is a presence of any apical aneurysm is there on. If you see these 2020 guidelines, which is published in Circulation, they have said that they have recommended that whenever there is a suspected hypertrophic cardiomyopathy or HCM, TT should be done in these patients. And whenever there is no change in the clinical status, again, we should do TT every 1 to 2 years. So TT should be done. That means the transthoracic echocardiography should be done in these patients. And if the symptoms recur, we should always do TT. And then in the patients with HCM and resting LVOT gradient less than 50 millimeter of mercury, then we should do TT with provocative measures. And the important from perioperative point of view, in patient with HCM undergoing surgical myectomies, intraoperative TE is also recommended in these patients to assess the mitral valve anatomy and adequacy of the septal myectomies. Again, there's a class 1 indication. Again, the class 1 indication is whenever we are doing the septal ablation also, again, we should do either TT or intraoperative transesophageal echo in these patients. These are all the class 1 indications of echocardiography in patients of HCM. What is the indications of cardiac magnetic resonance? Whenever the echocardiography is inconclusive, we should always do cardiac imaging, cardiac CMR in these patients, cardiac MRI in these patients. Whenever we are suspecting an alternative diagnosis like storage disease or infiltrative disease or athlete search, again, CMR should be done. Again, in another group of patients in which we cannot assess the diagnosis or they are high risk for sudden cardiac death, in those patients also, we should do cardiac MRI in these patients. How to approach with echocardiography? We should confirm the left ventricular hypertrophy. Again, very important. The second important thing from anesthesia point of view, what is the degree of LVOT obstruction, which is detrimental, systolic anterior motion of the mitral valve, assessment of the left ventricular function and the diastolic function. Diastolic function comes last because they are detrimental. Whenever there is a diastolic dysfunction, that means the disease is in the advanced stage. And what is the left atrial size? That is very important. Whenever we do see the echocardiograph, this was a paper published in Asian Annals with systemic approach to echocardiography in patients with these. So just to, I will I will not go into the detail, but I will tell you that it is just whenever there is a asymmetric septal hypertrophy, or whenever there is an unexplained wall thickness of more than 15 millimeter in any myocardial segment, that is significant. Whenever there is a septal or posterior wall thickness of more than 1.3 in normotensive patients, or more than 1.5 in hypertensive patients, again, it is significant. So these dimensions should be taken, or we should check the echo report. If the dimension is more than 15 millimeter in any segment, that is significant. If the ratio of septal to posterior wall of the left ventricle more than 1.3, it is significant in normal patient. Hypertensive patient more than 1.5. As you can see, this is a mid-esophageal long excess view. You can see this is the left ventricular hypertrophy. This is the asymmetric left ventricular hypertrophy. This is a septum, intraventricular septum, which is hypertrophic. There is a contact of mitral wall with the septum, which is significant. Again, you can see the hypertrophy of the left ventricle in the transgastric view. You can see how normally it is like that. The LV is visible. The cavity is visible. You can see the cavity is hardly any cavity. There is a kissing papillary muscle sign is there. Again, this is a deep transgastric view. You can see the LV is hypertrophic. This is the aortic valve. This is the mitral valve. So these views, you should either see it yourself or you can check the echo report in this patient. Second thing is the LVOT obstruction. Again, I'm like important, non-obstructive is 30, labile is more than 50, pressure gradient, and obstructive at rest is more than 50. Why it is significant? Any mark gradient of more than 50 millimeter of mercury, either at rest or at provocation. This is a threshold for surgical or percutaneous intervention. We should do septal reduction therapy in these patients if symptoms are not controlled by medication. First, we should try the medications. If they are not controlled, we should always go for septal reduction therapy, either in the form of septal myectomies or surgical management, or we can do the percutaneous interventions, and percutaneous alcohol ablation can be done in these patients. Now, if you see the echocardiography, what is the difference between the aortic stenosis and the shape of the Doppler wave in HOCM? There is a symmetrical like waveform is there in aortic stenosis, but in this HOCM, there will be a slight notch is there because of the contact of the mitral valve with the septum. And there is a formation of a gradient, and there is a. So again, the same things I am repeating. The pharmacological, that gradient of more than 50 is considered hemodynamic importance. We should do something whenever the gradient is more than 50 millimeter of mercury. How to check the systolic anterior motion? Again, an important thing, which is a dynamic obstruction. It depends on the loading condition and the contractility of the ventricle. Why it is important from anesthesia point of view? Whenever the patient is having hypotension with HOCM, we should not give inotropes in these patients, because increased myocardial contractility in these patients and decreased ventricular volume and decreased afterload, again, all these three will increase the LVOT obstruction. So whenever there is a hypotension in the patients with left ventricular hypertrophic cardiomyopathy, we should give fluids to these patients. The ventricular volume should not be decreased. The contractility, we should control the heart rate. The myocardial contractility should be controlled. Like it should not be like we should give adrenaline or we should give vasopressors to these patients. We should always control the heart rate, give fluids to this patient, and decrease afterload to decrease the LVOT obstruction, because it will increase the systolic anterior motion, leading to more hypotension. There is more contact of the mitral valve with the LVOT, and there is a hypotension, and there is a forward flow will decrease. More mitral regurgitation will be there. Now again, SAM, that may be mild, moderate, or severe. When there is or severe means prolonged SAM, there is septal contact of the mitral valve with the interventricular septum is more than 30% of the systole. That may cause hemodynamic instability. So it may be divided into mild if it is the septal distance is more than 10 millimeters, moderate if the septal distance is less than 10 millimeter, and there is a brief mitral septal contact. And when there is a prolonged mitral septal SAM, septal contact is there with mitral leaflet, and it is known as severe SAM. So we should check the IVS dimensions, thickness, what is the septal bulge. Already I have told you. And important is the length of the AML, anterior mitral leaflet length. Any length of more than 30 millimeter is important. More length, more contact with the interventricular septum, more chances of LVOT obstruction. And this is the AML. This is the AML length, any length of more than 30 millimeter is significant, or if there is an abnormality of the subvalvular apparatus, that also causes the LVOT obstruction. Just to see just the picture like echo picture showing the LVOT obstruction, I will show in another. And you can see in this picture, this is the mitral valve, this is the LVOT. Whenever there is a mitral leaflet septal contact will occur, this causes obstruction of the LVOT, and so hypotension will occur and more mitral regurgitation will be. This is a simple phenomenon. So this is a dynamic obstruction. If whenever there is a tachycardia, whenever there is a hypovolemia, this obstruction will increase, more hypotension will be there, more mitral regurgitation will be there. So we should control the heart rate and we should give volume to these patients. That is the basic essence of management of HCM patients. You can see there is a transesophageal echo. You can see there's a contact of the mitral valve with the intraventricular septum, hypertrophic ventricle. You can see there's a jet of the posteriorly directed jet of the mitral regurgitation. Along with there is a you can see the obstruction at the LVOT. So this jet is there posteriorly directed, which is because of the SAM and because of the HOCM. Systolic function, as I already told you, it is usually preserved in these patients. And usually we can do the spectral tracking echocardiography, which is, I think we should just overview of this, that how do we do spectral tracking. The important thing is the diastolic function. The diastolic dysfunction is there in patients with LV with HOCM with the increased left ventricular and diastolic pressure. Why there is a diastolic dysfunction? There is increased LV mass, there is hence hypertrophy is there. Because of that, there is a reduction of the cardiac compliance, chamber compliance. There is prolonged relaxation. Moreover, ischemia and myocardial fibrosis also occurs. That is significant. So diastolic function is very important. Dysfunction is very important in these patients. And these are the values, just to tell you, these are the values we do in our echocardiography, E by prime 4 than 14, LV volume index, PR peak velocity, and these things. But the important thing is we should measure the left ventricle, we should check the left atrial size in these patients and left atrial volume index. Volume index more than 34 ml per meter square, increase LA size, and is very important for an asymmetric dilatation of the LA is important marker of diastolic dysfunction in these patients. Again, 3D echocardiographies also complement the 2D echocardiography. We can assess the mitral valve in a surgical view, and just like surgeons see the mitral valve, we can also see that valve. Now coming to the intraoperative team, again, it's an important thing. I've already told you that according to guidelines, the class 1 indication of using in both as well as surgical as well as in the like alcohol ablation in these patients. It guides the like septal perforation. Now, according to echocardiography, what are the findings for posterior prognosis in these patients? Poor prognosis in these patients. Whenever the thickness, I have told you, of more than 30 millimeter of LV wall, the gradient of more than 30 millimeter of mercury at rest with ejection fraction of less than 50%. Left atrial diameter, already told you the left atrial diameter of 48 millimeters, again a mark of poor prognosis. LA volume of more than 27 per meter square at baseline, and intraventricular dyssynchrony of more than 45 milliseconds is again. These are the findings on echocardiography which denotes poor prognosis in these patients. Now coming to the treatment, just an overview of the treatment. Beta blocker is the first line of treatment in these patients, as it decreases the heart rate, which is important in these patients, and have a negative inotropic effect, thereby prolonging the diastolic time and improve the LV filling. Amiodarone can be used if there is superimposed other like arrhythmias like supraventricular tachycardia or ventricular tachycardia. We can add on amiodarone or calcium channel blockers. And that we should have like implantable cardioverter defibrillator. AICDs are implanted in selective group of patients in which there is a sudden cause of sudden death or risk of sudden death is there. Otherwise, according to guidelines, we should do either the surgical myectomy or alcohol septal ablation. So these are the guidelines. According to 2020 guidelines, beta blockers are the first line of therapy. If the beta blockers are ineffective, we should add on calcium channel blockers. We can also add on disopyramide, a combination of these drugs, or whenever there's a hypotension occurs, then we should give some phenylephrine type of drug in these patients. Now, these are the recommendations of AICD. Whenever the history of previous cardiac arrest or sudden ventricular tachycardia, AICD is recommended. And whenever there is a family history of sudden death, you should always go for AICD in these patients. And septal myectomy, this is the septal myectomy, this is the part of the muscle which is cut. The mortality is less than 1%, but the problem is that there are perioperative complications of new onset of atrial fibrillation. There may be ventricular septal defect occur, that is iatrogenic. If we cut a lot of septum during surgery, there may be iatrogenic VSD occurs, and there may be aortic insufficiency. So this is the hump, and this is after surgery. You can see the hump is like we have cut the muscle, and the LVOT is clearly visible. Now, echo septal ablation is another technique where one of the septal perforators of the coronary artery is injected with 1.5 to 2 ml of alcohol, and that leads to, now this is done in our institute. This is the wire which is injected into inserted into one of the septal branch of the LAD, and then the alcohol is inserted. You can see this is the alcohol, 1.5 ml. It's the absolute alcohol. So coming to the again to the treatment, first is the beta blockers. If side effects, we can use calcium channel blockers. We can add disopyramide. Then comes the role of mechanical therapy in the form of septal reduction therapy, in the form of septal myectomies or ablation or AICs. And whenever there is a sudden cardiac death, we should always use AICDs in these patients. Just revision of that. So these are the guidelines according to 2020 ACE guidelines. In symptomatic patients with obstructive symptoms, septal myectomy is the first line. This is the class 1 indication of treatment in these patients. Patients with serious comorbidities, advanced age, or alcohol septal ablation should be used in these patients instead of surgery. The patients who are not fit for surgery or old age, comorbidities, we can use alcohol septal ablation in these patients. And in asymptomatic patients, we should not do septal reduction therapy, and that anyway will harm the patient. And we should also not do mitral valve replacement if it is like the symptomatic patients in which mitral valve is normal. We should not do anything with it. Now coming to cardiomyopathy and anesthesia. Now why it is important, particularly from anesthesia point of view, particularly for non-cardiac surgeries. There are a lot of papers which are published, like this paper was published, what are the perioperative anesthetic concerns in patients with HCM for non-cardiac surgery in Annals of Cardiac Anesthesia. Again, there are anesthetic and surgical considerations were published again in Annals of Cardiac Anesthesia. Then another paper was published in patients with hypertrophic cardiomyopathy, patients undergoing non-cardiac surgery, that is the proverbial Pandora box. But they found that the role of LVOT obstruction. We should always assess the presence of LVOT obstruction in patients diagnosed with HCM undergoing non-cardiac surgery. The degree of LVOT obstruction determine the hemodynamic consequences during surgery. Now, what are the perioperative goals in this patient? We should maintain adequate preload and afterload in these patients. We should maintain the systemic vascular resistance, that is afterload. We should avoid sympathetic activation in these patients. Again, should reduce contractility. We should always avoid sympathomimetic drugs in these patients. We should avoid tachycardia. We should maintain normal sinus rhythm in these patients. And again, the same thing, the fluid boluses and alpha adrenergic agonist is the first line, phenylephrine is the first line to prevent the LVOT obstruction. So this is in a nutshell the perioperative goals in this patient. Whatever surgery is going on, these goals should be like avoid tachycardia, avoid the preload should be maintained, afterload should be maintained, the contractility should be maintained. There should not be any force of contraction, should not be increased. Regional anesthesia again should be used with caution in these patients, as sympathetic blockade and decreased preload and afterload are dangerous in these patients. And general anesthesia, particularly in obstructive HCM, is considered safe in these type of patients. So in a nutshell, that if you see the anesthesia technique, the induction should be with the titrated doses of propofol or sodium thiopentone you can use, but it should be titrated, and we should decrease, like maintain the afterload in these patients. And the thiopentone should be used very slowly. Etomidate is an option, provided the sympathetic ablation is provided by adequate doses. So we should balance it with opioids so that there should not be systemic activation in these patients with etomidate. Hypotension, we should use judicious preloading in these patients. Again, we should use alpha adrenergic agonist in the form of phenylephrine. And like all sympathomimetic agents like beta-adrenergic agonist, like dopamine, dobutamine, epinephrine, isoprene should worsen the LVOT obstruction, because that will lead to a positive inotropic and chronotropic effect that should be avoided in these patients. And continue DD. If the patient is on pacemaker, we should continue pacemaker during surgery. The pressure response, the pre-treatment should be with metoprolol, beta blockers should be used judicially in these patients. Muscle relaxants without histamine release like atracurium and like evaluatics property should be used in these patients. Like atracurium should be avoided, pancuronium should be avoided. Sevoflurane can be preferred in these patients. Nitric oxide is not preferred because it causes sympathetic activation and increased PVR. Dexmedetomidine reduces the heart rate, is an important drug, and block the sympathetic stimulation. And we should, particularly with regard to mechanical ventilation, low tidal volume, and we should avoid PEEP in these patients. Again, we should preoperative assessment of the fluid status and optimization of the medical therapy. Again, LVOT obstruction is very important. Invasive monitoring is very important in the form of arterial blood pressure and CVP or PA pressure whenever required. That depends on the degree of surgery, what surgeries you are doing. T is very important, particularly from cardiac surgical point of view. If it is available, it can be used in non-cardiac surgery to assess the fluid status, to assess the biventricular contractility, to assess the left ventricular and diastolic volume and end-systolic volume. Again, this is very, very important, the diastolic volume and end-systolic volume. Inotropes, I will again repeat, should be used with extreme caution as it will increase the LVOT obstruction and MR, and that may lead to pulmonary edema and cardiovascular collapse in patients with severe LVOT obstruction. These are general things which we can do in, and you can see this is the transesophageal echo we are using routinely in our patients. Now, coming to a subgroup of patients like HCM with parturition, like Dr. Mukul will tell you about the peripartum cardiomyopathy, but what happens in pregnancy? It increases the stroke volume, increase heart rate, decrease SVR, there is a concentric remodeling hypertrophy, and whenever, along with HCM, it will further exacerbate the problem. Increased volume load occurs to the heart and which cannot dilate. Already a stiff ventricle is there, tachycardia also there, that shortens the diastole, and it is a very bad hemodynamic effect occurs in these patients. So we should optimize the heart rate with using beta blockers, calcium channel, any drugs which maintain the heart rate, optimize the preload, whether we have to balance between the volume and the diuretics. Pre-oxygenation is very important and maintain the saturation more than 95%. If not stabilized, then urgent cesarean should be done. And after delivery, we should do the optimized preload in these patients and consider diuretics and volume depending on the hemodynamic monitoring and the CVP of the patient. There was a paper published in in 2013, like what is the pregnancy in patient women with hypertrophic cardiomyopathy. What they have suggested that we should use epidural analgesia, white spinal. We should do isobaric solutions. Ropivacaine can be preferred. It is more cardiostable. Then, before pregnancy, we should assess the symptoms. We should do regular echocardiography. We should start the medication before pregnancy. Genetic counseling is very important in these patients. Risk assessment and counseling during pregnancy. Follow up each trimester for low risk and monthly for every patient with increased risk. Continue beta blockers. Prompt treatment of arrhythmias like atrial fibrillation. Delivery should be vaginal if it is possible. Blood pressure and rhythm monitoring should be done. Monitor preload echocardiography. Echocardiography has a very important role. Oxytocin should only be used with slow IV infusion, and we should clinically observe the patient at least for 24 to 48 hours and after delivery. In case of laparoscopic surgery, particularly with regard to pneumoperitoneum causing hypercarbia, elevated intra-abdominal pressures that may have detrimental cardiovascular effects, particularly in this subgroup of patients. Sympathetic activation, decreased venous return occurs. So ideally, we should maintain intra-abdominal pressure of less than 15 millimeters of mercury, and duration of pneumoperitoneum should be as short as possible, and a fast expedite surgery should be done. And there is another paper which was published in Journal of Cardiothoracic Vascular Anesthesia, and what is the safety of non-cardiac surgery in patients with HCM at a tertiary cardiac center. Preferably, these patients should be done in tertiary cardiac centers. And as all facilities are available, as there are more chances of going into the heart failure and severe perioperative cardiac symptoms in those patients, more chances of cardiovascular complications are there. So ideally, they should be done in a tertiary care center. So just to conclude, HCM is a disease with significant hemodynamic implications. Early diagnosis and treatment is important for clinical management. Understanding the pathophysiology of cardiomyopathy is important, particularly with the LVOT obstruction for effective perioperative management. Preoperative assessment of fluid status, optimization of the medical therapy, along with invasive monitoring and echocardiography, particularly T, is very important for perioperative care, and regional anesthesia should be avoided in these patients. Thank you very much.
Thank you very much, Dheeraj, for a very comprehensive coverage of a very important topic, which is not very well discussed most of the time in teaching. And I would say that the people should take back lots of messages from this talk, and especially the messages are that most often when non-cardiac surgery is done, people are trying to improve the blood pressures and they use inotropes. Negative inotropy is the forte of management of HOCM, which is something which is not commonly followed by non-cardiac anesthesiologists. So they should remember this very important thing, negative inotropy. The negative inotropy is one of the most important things to manage in this case. And the next thing, which again Dheeraj just pointed out, is laparoscopic surgery is very common today. Robotic surgery is very common today, and it is in these kind of surgeries that you have more problems with patients of obstructive cardiomyopathy because of, as he had very nicely pointed out, that because of the changes in the venous return, the decrease in the venous return, and also because of problems of positioning, that everything gets aggravated in hypertrophic obstructive cardiomyopathy. So I would like to caution people about the fluid part at least. The thing is, though fluid can be given easily to patients with cardiomyopathy, but the ones which have got very severe diastolic dysfunction, you have to maintain the optimum balance. You can't overload them also because they land into pulmonary edema. So you have to be very careful balancing everything. And I would say that whenever you do a hypertrophic cardiomyopathy, which is a reasonably maybe a major case, you should always put an arterial line to be safe, because that will be one of the first ways to find out that your cardiac output is going down or you're landing up into a problem. Thank you, Dheeraj, for an excellent talk. Thank you very much. So we now move to the other part of the spectrum. This was hypertrophic obstructive cardiomyopathy, and I will be talking about peripartum cardiomyopathy, which is on the other side of the spectrum, that is in patients who have got dilated cardiomyopathy, which is related to actually to purpurium or pregnancy. So peripartum cardiomyopathy is something which comes as a surprise to you, and people who practice obstetric anesthesia suddenly get foxed when just before they have to take the patient up for surgery, or immediately during surgery or after surgery, they have a person who has gone into low cardiac output, and everybody is in a fix. They don't know what has gone wrong, and that is the time when somebody does an echo, and then you find out that the patient has developed peripartum cardiomyopathy. So it comes generally as a surprise. I've seen lots of cases in which were not diagnosed preoperatively, taken up a cesarean section, and suddenly the anesthesiologist lands in trouble because what happens is you don't tend to do an echo for somebody who has come for cesarean section. You don't tend to do an echo just before the cesarean section, and this happens in either the last week of pregnancy or during labor or immediately after the delivery. So this comes and foxes you and gets you into trouble. Sorry, it didn't move. Okay. So I'll be talking about this in different parts of my talk. These are the headings which are there. I'll not enumerate on the headings, but I'll initially come to the definition of peripartum cardiomyopathy. Peripartum cardiomyopathy is a relatively rare form of dilated cardiomyopathy, and it is basically described as a deterioration in cardiac function, which typically presents in the last month of pregnancy, but can occur up to 5 months postpartum also. It involves a sudden systolic dysfunction, and the patient lands in congestive heart failure with a reduced left ventricular ejection fraction, may even present as with some features of thromboembolism, ventricular or atrial arrhythmia, and at times even sudden death. It's basically a diagnosis of exclusion. It is not a primary diagnosis based on some features which are present, but it's a diagnosis of exclusion when all other forms of cardiomyopathy or dilated cardiomyopathy have been excluded, that you decide that you can classify this as a peripartum cardiomyopathy. When you come to the historical background, it was in 1870 that Virchow and Purek they did autopsy of patients who had died of myocardial degeneration and who had died during puerperium. And when they did an autopsy, they found that the patient had myocardial degeneration, and they were wondering patients without heart disease having myocardial degeneration suddenly after childbirth. And it was in 1937 then again Gole et al. Described features of some seven patients in which they did a autopsy, and they and who had died basically of fatal heart failure, which included dilated cardiomyopathy, which was diagnosed in the later months of pregnancy. 4 of them had died, and autopsy revealed the autopsy of the 4 of them who had died revealed that the patient had dilated cardiomyopathy with widespread areas of necrosis and fibrosis. Now, coming to the nomenclature, I said I used the word peripartum cardiomyopathy in the beginning, which is the currently most accepted nomenclature for this disease, but it has also been called as toxic postpartum heart disease, postpartum heart failure, postpartum myocarditis, and postpartum heart disease also. What is its prevalence? Prevalence is a little varied from 3,000 to 15,000 pregnancies. You have one case of peripartum cardiomyopathy. It has been reported more often in Africa. Though the incidence is supposed to be higher in Africa, it is seen in all races of mankind. It is not restricted to Africans only. Its prevalence is probably more in Africa only. So Africa is one place where you have these heart failure clinics and patients who are postpartum regularly attend these heart failure clinics because the incidence is much higher than other parts of the world. If you look at the number of patients who are presenting with postpartum cardiomyopathy or peripartum cardiomyopathy, you see the number has been steadily increasing over the years. If you look at from this study, which was published in the Journal of American Heart Association in 2024, this has shown very clearly that the rate of detection of this disease is increasing as the time is passing. More and more people are getting detected with it. So if you when they try to compare it with the age of the patient at the time of maternity, that means patients who were older at the time of maternity had greater chances of developing PPCM. That is the reason why it is detected more now, because more and more people are, having children at a later age. So the chances of peripartum cardiomyopathy increases as the lady is getting older and older. So that's the reason why the incidence also is rising in the last few years. When you look at the incidence again, if you look at the age based on this publication, which was in the BMJ, and this publication also has shown similar things. It has also shown that in the United States, if you look at the yellow bars are the women who are in the age group of 40 to 54. The trend is that women who are older tend to develop peripartum cardiomyopathy much more than women who are younger. So as the age increases, the incidence of peripartum cardiomyopathy keeps on increasing. What are the contributory factors? There are multiple contributory factors. Multiparity is one factor. Advanced maternal age, multifetal pregnancy, preeclampsia, maternal placental syndromes, gestational hypertension, cocaine abuse by mothers, selenium deficiency, and long-term tocolytic therapy with beta-2 agonists. That is another thing. So people who have threatened abortions, they are more prone to develop PPCM. They are the ones who threatened abortion patients are the ones who are put on oral tocolytic therapy, and they are the ones who get more prone to develop PPCM. So this has again been summarized in this thing. And another thing which has been added here is one is cocaine use is, of course, which was highlighted earlier, and selenium deficiency has been added here. And plus history of mucopolysaccharidosis also increases the chance of a patient developing PPCM. Coming to the etiology, now multiple things have been implicated to have caused PPCM. One is cardiomyopathic viruses, toxins triggering the immune system. Genes have also been implicated, and autoimmunity or immune system deficiency, and the deficiency of micronutrient and trace trace minerals also have been implicated. Multiple things, nothing proved till now. What is the mechanism? It is not known how the inflammatory response in the heart is triggered. We don't know. But what happens after the inflammatory response is triggered is the heart muscles undergo necrosis and thereafter form scars, which leads to a fall in the left ventricular ejection fraction. There's a damage to the cytoskeleton of the heart, and this leads to, again, systolic dysfunction and a fall in the cardiac output. It is thought that this is initiated by an immune process, and there is immune related inflammation in the heart. Gradually, it causes a progressive loss of cardiac tissue, contractile tissue. What I mean is contractile tissue, and leads to congestive heart failure. When you look at this publication which was there last year only, then it's a very interesting way they have tried to describe it. So what happens is, over the years, as pregnancy proceeds, the patient starts increasing the cardiac output, the cardiac mass keeps on increasing. Along with that, there's an increase in the hormone levels also, especially the hormonal levels of prolactin. And with the increase in the prolactin and oxytocin hormones, it is said that this contributes largely to the development of the increase in the levels of prolactin contributes largely to the development of PPCM. Apart from this, there are other things which have been implicated in this thing. But if you see the incidence of PPCM, if you look at that, the incidence has been very clearly shown to be a week before delivery and up to about a month after delivery. So this is the area in which, and this is the time when all of these are peaking. So it is thought that the peaking of these hormones and the peaking of the hormones and some other elements which are excreted by the placenta actually contributes to the development of PPCM. So it is said that prolactin levels, they make changes in the endothelial and the endothelium of the uterus, and causing endothelial dysfunction, which causes release of various factors which cause cardiomyocyte death and also necrosis. Similarly, certain factors released from the placenta also cause a fall in the cause a dysfunction in the myocardial muscles and cause cardiomyocyte apoptosis. So what happens is basically a phase of myocarditis, which is followed by necrosis and dilated cardiomyopathy thereafter. This is a major study which is quoted basically about PPCM, that is called as the Nairobi study, which was done in 1986, and which 11 women, African women, were studied for PPCM. They did endomyocardial biopsies, and in the endomyocardial biopsies, they found evidence of healing myocarditis in 5 patients out of 11. And they also found necrosis and fibrous remodeling in them with the presence of inflammatory cell. 75% of the patients who had myocarditis developed persistent heart failure. Out of the patients who developed myocarditis, 80% improved with time. 80% of people who did not have features of myocarditis improved with time. Another study done during the same time on 84 women with cardiomyopathies, they said that 14 of them could be put under the classification of PPCM. And out of these 14, 29% had evidence of myocarditis. Another study done a few years after that on 18 patients with PPCM, they found 14 of these 18 had myocarditis. And because they had myocarditis, they were given treatment with immunosuppressants over 6 to 8 weeks. And after giving this immunosuppression, 9 out of 10 improved with therapy. That means immunosuppression helped those patients. Remaining not receiving the therapy also, so many of them improved without therapy. So it's basically an abnormal immune response. As per the paper published in 1998 by Nelson et al., they said that fetal cells may lodge in the cardiac tissue without rejection, triggering an immune response. So fetal cells released from the placenta and from the uterus, they are the ones which come and lodge in the cardiac tissue, and they are the ones which trigger the immune response. 39 women with PPCM showed no difference in the immunoglobulin levels or the cardiac muscle antibodies between subjects and the control in the Nigerian study. However, now coming to genetics, there's a lot of thought that genetics plays a role because of the following studies. Pierce et al. Found that 3 out of the 17 patients with PPCM had a family history of the same condition. So it occurs in families also. Was et al. Found that a patient who had died of PPCM also had a mother who had died and 2 sisters also had died of PPCM. So it runs in families also. Then Masad et al. Found that a 16-year-old girl with PPCM following a molar pregnancy, her sister needed a cardiac transplant again because of PPCM. So again, a strong genetic connection. And the worst was Strung et al., who found that even male relatives of female patients with PPCM had cardiomyopathies. So obviously, there seems to be some genetic predisposition to PPCM. What are the clinical features of PPCM? The common signs and symptoms of PPCM are orthopnea, dyspnea on exertion, pitting edema, cough, frequent nocturnal urination, excessive weight gain in the last month of pregnancy, palpitation, arrhythmias, ectopic beats, and chest pain. These features are typical of congestive heart failure. They are not specific for PPCM, but they are typical of congestive heart failure. They can happen in any form of congestive heart failure. And in addition to that, there is swelling of feet, and patient has cough because of pulmonary edema. Early symptoms, generally what happens is people tend to ignore the early symptoms of tiredness, etc., thinking that it is pregnancy which is causing it. But it is very important that these features are detected early and the diagnosis is made early. At times, the patient presents with evidence of embolization to a vital organ, causing a stroke, limb ischemia, or coronary occlusion because of MI. So why is it not diagnosed early? Because the third trimester of pregnancy, because of increase in the blood volume in the patient may have things like which are just like congestive heart failure they may have jugular venous distension also. And later months of pregnancy also you have pedal edema, dyspnea and fatigue are very common. And what happens is these changes may unmask subclinical or compensated heart disease because of the increase in blood volume of pregnancy. How should you investigate these patients? The ECG will show sinus tachycardia, non-specific ST and T wave abnormalities, voltage abnormalities. Q wave are occasionally present in anterior leads. PR and QRS interval may be prolonged. Echocardiography, when done, shows clear evidence of decreased LV systolic dysfunction or function. So if when you look at the echo, you can see the LV is grossly dilated. When you look at the LA, again, the LA is also dilated. And you do a color Doppler, you'll find the evidence of mitral regurgitation because of the incompetence of the mitral valve because of the dilatation. And when you do an M board, again, you can see evidence of LV dilatation. At times, you may find evidence in the form of an LV thrombus. So LV thrombus may be present at the apex and which can always dislodge and cause a thromboembolism episode somewhere else in some other organ. So what are the diagnostic criteria for diagnosing PPCM? Is development of cardiac failure in the last month of pregnancy or within 5 months of delivery. And generally, it is associated with an absence of any identifiable cause of cardiac failure. There is absence of recognizable heart disease prior to the last month of pregnancy. So that is an indicator of PPCM, and systolic dysfunction is there in the form of LVEF less than 45%. What is the treatment? Treatment is similar to treatment any congestive heart failure using diuretics, beta blockers, and digoxin. Diuretics basically to offload the volume which is there in the patient and decrease the blood pressure using that. And hydralazine with nitrates can be used, especially in patients because they are breastfeeding and it is not safe to use other kinds of drugs. Anticoagulants must be started during is an important therapeutic option during this phase. So the medical management of PPCM has been very well described in this particular chart, and the green ones is what is recommended in the case the patient is pregnant. You should use restrict yourself to loop diuretics, beta blockers, hydralazine or nitrates, and digoxin. ACE inhibitors or ARBs can be used, but they should not be used during pregnancy. They can be used after pregnancy. ARBs and ACE inhibitors can be used after pregnancy. Similarly, as far as anticoagulants is concerned, you should use low molecular heparin, but not use warfarin for obvious reasons. During pregnancy, they cause various kinds of fetopathy and embryopathies. So in case the LVEF is less than 35%, anticoagulation should always be done. You should always be ready and the patient be prepared for implantation on an LVAD or a heart transplant in case the patient's condition deteriorates and in case the patient does not improve. Investigate the patient after the childbirth with a cardiac MRI, with a cath, and with endomyocardial biopsy. Consider using antiviral therapy because, as I said earlier, cardiomyopathy, cardiotrophic virus is also implicated to cause it. So consider antiviral therapy, immunoabsorption, IV gamma globulins, and immune modulation therapy. ACE blockers can be started after the pregnancy is over, and along with beta blockers, they can be given and they can be continued for about a year after childbirth. Cardiac transplant is an important consideration in patients who do not improve despite therapy, and the patient should be strongly advised against future pregnancies because future pregnancy may worsen the condition of the heart. And future pregnancies are associated with an increased risk of hypertension, preeclampsia, and preterm labor. And also there is a chance of a graft failure in case you do a heart transplant and then the patient goes in for pregnancy. There is a great chance of graft failure occurring during that period. It's an interesting thing. I would like to tell you that the first cardiac transplant we did when I was in the armed forces was done on a 32-year-old lady with PPCM. So that was the first lady in which we transplanted the heart. This patient had a normal delivery a year back and then suddenly developed dilated cardiomyopathy immediately after delivery. She was not responding, her CHF was not responding to therapy, and she developed mitral regurg. Along with that, LV ejection fraction was less than 20%. So since she was not controlled with diuretics and anti-failure therapy, and she was on inotropes, she was taken up for heart transplant. Coming to the prognosis, mortality estimates range from 25 to 50%, and most patients die within 3 months postpartum, and death is usually caused by progressive pump failure, arrhythmias, and thromboembolic events. In a study published in the International Journal of Cardiology, in which they studied 20 patients, 16 who presented in NYHA class 4 and 4 in NYHA class 3. With therapy, 12 patients improved to class 1, 7 patients either failed to improve or deteriorated, and 1 person died. So if you can see, the death mortality is very high despite therapy. So when you try to track the outcomes of patients, more deaths occur within 3 months postpartum. Initial evaluation data provided by some studies clearly says that the mean follow-up should be there for at least 6 months, and you should continuously assess the patient's class status and see if the patient's condition is improving. Again, in the patients, in the study on 123 patients with PPCM, 59% of patients recovered and achieved an LVEF of greater than 50%. In 41% of patients, LV dysfunction persisted. So a very high number of patients continue to display LV dysfunction despite therapy. 4% of these needed heart transplantation at a later stage, and 10 of them died. So out of 123 death, 10% died. So it's a very high rate of mortality. But when you consider cardiomyopathy due to other causes like ischemic heart disease, idiopathic cardiomyopathy, and HIV infection, the proportion of patients surviving with peripartum cardiomyopathy is much better than the others. So things are a little better there. But if you look at mortality rates, how they are over the years, if you see the mortality rates haven't fallen much. If you see this publication from in which they considered patients from 1986 to 94, they had a mortality rate of 18%. And this publication from 83 to 98, less than 10%, this publication showed. But again, a publication in the 2000s, the mortality rate was again 15%. So the mortality rate hasn't come down much. So in case the patient decides to have a future pregnancy, it should be very individual approach. The patient should be educated about the risk and maternal as well as fetal mortality. Always involve the cardiologist in decision making. The cardiologist should be involved right from day one of pregnancy. Serial echocardiograms must be done and sonograms done for growth of the child also along with that. Again, a very interesting thing, in case you know that the patient has developed PPCM and the patient needs labor analgesia. So in case the patient needs labor analgesia, it is advisable to start invasive monitoring during that phase itself, which includes arterial line and a PA catheter to assess the hemodynamic status and guide the management of the patient thereafter with the help of these invasive lines, because the stress of labor and delivery may cause severe cardiac decompensation. Actively use vasoactive agents such as vasodilators to reduce the preload and afterload, and inotropes or inodilators to improve the cardiac output. Remember to guide your fluid therapy based on the PA catheter rather than just arbitrarily giving fluids. In case you decide to give epidural anesthesia to these patients, you should start it early to minimize the cardiac stress. You should do a slow induction of the epidural analgesia. Do not give a large amount of drug in the beginning, give it slow, and a graded epidural is what is recommended. Fluid management, again, should be using a PA catheter, and you should ensure that there is a reduction in the myocardial afterload when you're doing these cases. As combined spinal epidural analgesia also can be used, but it is better to use only intrathecal opioids as far as the spinal injection is concerned. Only use opioids rather than adding local anesthetics to that, and do a very slow titration of the drug so that the afterload reduction is very gradual. And in case if you want, you can use continuous spinal anesthesia also, but you should supplement the local anesthetic with opioids even during the spine, even in this continuous spinal. If in case the patient has to come up for cesarean section, it is best to use either continuous spinal anesthesia but continuous spinal anesthesia as far as possible should be with only opioids. So the drug of choice, the method of choice, is doing the cesarean section in a graded kind of epidural, monitoring the hemodynamic status and the fluids, and using single short spinal, remember, is a no-no. Never use single short spinals because the sudden fall in afterload will precipitate heart failure further. In case you have to give general anesthesia, avoid drugs which cause myocardial depression. Use a high-dose opioid technique, even if you have to use post-operative ventilation thereafter, but use a high opioid technique. Use short-acting opioids with short half-lives, minimizing the depressant effects on the neonate. And in case neonate can has a respiratory depression, your neonatologist should be ready and prepared to manage the neonate. As far as the prognosis is concerned, mortality varies from author to author and from the follow-up duration of different studies. There's an increased risk for future pregnancies. Data from several studies have clearly shown that the mortality and the transplant rates are very high in future pregnancy. So I'd like to show this particular chart, which was published in the article Davis et al. In Journal of American College of Cardiology in 2020. which very nicely, this infographic very nicely summarizes the entire management of peripartum cardiomyopathy, not the anesthetic concerns, but general overall management of peripartum cardiomyopathy. It's a good idea to go through this or download this chart, keep it in with you for future reference. Thank you very much. With this, we end the presentations, and now we are open to further discussions and questions. So no question has come up till now. So in the meantime, I think there's something. No, only thank you for the compliments, sir, Dr. Belani, sir, and Dr. Muralidhar Khanchi, sir. Thank you for the compliments, and it was very nice to have you listening to us also, sir. It is very nice to have such eminent people listening to us, and it's very encouraging for all of us that you have heard us. And I would like to say that we tried to cover two ends of the spectrum of cardiomyopathy, and one in which there is hypertrophy, and the other in which there is dilatation of the heart. And basically to inform the younger generation about how different cardiomyopathy can be as far as the spectrum is concerned. Since there are no questions, can I hand over?
Sure, Dr. Kumar Belani may be able to sum up. Will you be available, sir?
I enjoyed, thank you, sir. I enjoyed both of the presentations. They were very comprehensive, and I think they both detailed not only the epidemiology, but also the pathophysiologies and the frequency of occurrence, and how we may see these patients present to us during the perioperative period, how we need to take care of them, and especially the dilated one, which can show up, like Dr. Kapoor said, suddenly, and we are not actually ready for them. So this is a great, these two presentations are excellent and should serve as excellent lectures for our trainees to listen to. And I think since the presentations are open to anybody in the world, they can be also seen by our collaborators in Africa and other countries where anesthesia is not very advanced. So thank you. Enjoyed the presentations, and I'm glad that they will be available in the future through the YouTube channel.
Dr. Muralidhar, are you available?
Yeah, very much. I loved both the talks. Very well done. Actually, I was really impressed with the quality of the presentation. It's updated information, and I would like to congratulate both these speakers. I would like to make a passing mention for each of the talks. One is that in the first talk, HOCM, in previous days, we used to think that halothane is a preferred inhalational agent for these patients because it provides anesthesia, at the same time does not increase the contractility, actually decrease the contractility. Maybe this may be a good drug in these patients. That's one comment I would like to make. For the second lecture, I'm not sure whether, if I missed it, the role of ECMO is being investigated in patients who have peripartum cardiomyopathy with excellent results. Actually, anywhere from 60 to 80% of these patients can be salvaged if they have a cardiovascular compromise which is not responding to conventional treatment therapy. So these are the two observations I would like to make, but otherwise I was thoroughly impressed with the presentations, and thank you so much for this webinar. Thank you very much.
If there are no other inquiries from anybody, I request Dr. Kumar Belani to conclude the session with a word of thanks.
Second, can I add one more thing which I missed?
Yeah, please.
One thing that, footballers have incidents of sudden cardiac death, and they cause the HOCM most of the time. The sudden cardiac death in footballers is commonly seen, which I think everybody should be aware of, is generally HOCM.
Yes.
Belani, sir.
Thank you. I think I'd like to thank the organizing committee of the Indian College of Anesthesiologists for doing these weekly webinars. In particular, I'd like to thank Dr. Radhakrishnan for introducing the session, Dr. Jayashree Sood for giving the comments at the beginning, the two speakers, Dr. Dheeraj Arora and Dr. Mukul Kapoor, and also Dr. Muralidhar Kanche, the Dean of the Indian College of Anesthesiologists, for providing valuable comments like the use of ECMO. Just one question I had, Dr. Kanche, is this ECMO for patients who are actively pregnant or is it postpartum?
It's usually postpartum. After that, we try all the conservative methods and do the hemodynamic measurements, go by the cardiac output and the filling pressures. If the cardiac output is low and filling pressures are high, not responding to the conventional treatment, we know arterial ECMO comes handy in these patients and the results are quite impressive.
We should put the data together and see if we can get that out there as a publication.
Sure,
Anyway,
sure.
thank you so much, and thanks to ClearNet for hosting this session and the previous sessions, and for the continuous collaboration. Goodbye.
Thank you so
Good
much,
night.
Thank,
Thank you,
thank you.
Rimpa.
Thank you so
very
much,
much.
everyone.
Thank you, Dheeraj. Thank you, Mukul.
Thank you. Thanks, sir. Thanks a lot, everybody. Thank you for giving us the opportunity. Thank you.
Thank
Thank
you.
you. Thank you. Bye-bye.
Thank you so much, everyone, for joining the session. ClearNet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session over here. Thank you
Thank
so
you,
much.
Rimpa and Planet.
Thank you, sir.
Yeah. Good night.
Yes, sir. Good night.